Okay, guys, let's talk about this case that we have in a few days. So, Dr. Ku, you're doing surgery.
Yes.
And then I saw the consultation originally. So, she was talking, I believe the story was something like 5 or 6 years ago, however many
Yeah,
years?
2019.
2019.
Mhm.
Okay, so 2019, she had an upper all-on-4 done, and she started experiencing loosening of the prosthesis. Something was getting loose,
Yeah.
right? So she came in. This is based off of my recollection. I looked at the X-rays right off the bat. I could see bone loss that's occurring on the distal implants. Definitely noticing that the implants are shorter, and also she has like a longer cantilever.
hmm
So just kind of, actually, I think the reason why this patient's having her issues is that it's a kind of like an issue of surgical potential. I don't want to say error, but maybe some things could have been done better surgically, but also prosthetically too. So let's start with you. Prosthetically, I wanted to give a little bit of background context to this conversation too. When this patient came in, she said that she went to another all-on-4 center in Mckinney. She had the all-on-4 done only on the upper because of finances. She was in her 40s. She was having a lot of issues. And correct me if I'm wrong. She was having a lot of like dental issues, so she was like over it. She wanted to get something that was going to be longer lasting. All-on-4 was going to be that solution for her, and but she could only afford to do upper, which is what we see a lot of patients, especially our female patients, want to usually if they have to pick one arch, they're going to pick their upper, right?
Yeah.
Especially for like aesthetic reasons. So she only did upper. Now she told me that she went in when she was experiencing issues recently. She went again to the same place that did her all-on-4, and they were telling her that her all-on-4 was failing because she didn't do her lower, right? And so I was thinking that it was failing because these implants are definitely not long enough. When we measure this on the CBCT, it's only 10 millimeter long implants. She has large sinuses. They're pneumatized, meaning they're low. And also she has a long cantilever,
hmm
right? But then also like when she said that to me, I was like, I doubt the reason why your all-on-4 is failing because you didn't do your lower arch, which is what they were kind of like trying to throw it back on her, saying that you didn't do your lower arch, and because your dentition is like this is the reason why your upper all-on-4 failed. Therefore, you need to redo your upper and do your lower, and it'll be around $70,000 is what they told her. So she was a little concerned by that, and then she sought us out. But I want to hear what your opinion, both you and Dr. Lazzaro, like in regards to like being prosthodontist. What is your perspective in regards to like what we're seeing right here and what may have contributed to this failure?
Yeah. So when I saw the patient, first off, right off the bat, we were just evaluating the prosthetic, and the prosthetic was actually loose. So
Okay,
we could actually wiggle it out. Quite a bit of play there. And when
and we
we,
could see that right there,
yeah,
right? That you see those
yeah.
gaps.
So there's definitely like a passive fit issue just to start with. So I think the way that the prosthetic was manufactured, I think could have been done better. I feel like the screw channels are all straight, and they didn't try to use any multi-unit abutments, which
Right,
help us to kind of angle all the kind of, just like you want the legs of a table to be straight.
right.
The same principle applies here. We try to make it all straight, but in here you can see all the screw channels are pretty much not corrected essentially.
So they're replacing the implants to avoid the sinuses, trying to maximize the bone contact. But then the problem is that then that was creating a not using multi-unit abutments. There was no readjustment of the angulation, therefore creating a passive fit issue.
Exactly,
Right,
because it's very hard to manufacture something when the holes aren't relatively parallel.
right.
That's what we try to do in our office, that we try to use photogrammetry so that we can try to kind of get the exact angle of divergence, which essentially helps us to fabricate a more sound prosthetic.
Right. Right.
Second,
Especially over the long haul.
absolutely.
Right. So long story short, this wasn't designed for some like, the long haul, right?
Yeah.
So what
And,
else?
and like you said, the cantilever itself, cantilevers are usually okay. Sometimes we do them as well.
Right.
However, I think that the cantilevers was not executed right because there's only essentially 2 points of contact, one here and one on the back there.
Yeah.
And both of these teeth are pretty supraerupted, which means they're pretty high up in the occlusal plane.
Yeah.
And we did see them. We can put up some photos as well to show. These turned into like interferences, which is almost like when the patient slides their lower jaw forward, they're supposed to be able to freely glide their lower jaw so that it slides very easily. But when the patient was doing this, just because of the design of the prosthetic, the patient was actually hitting this tooth, and you can actually see that the
chipping
filling is
out.
actually fractured off.
Right.
There's a big cavity now in it, and this tooth is actually not restorable anymore.
Right.
So I think that they should probably have taken these two teeth out, or perhaps maybe even capped them. Made sure that the level was better. Because right now you also see like an inverse relationship, because they're trying to meet the upper prosthesis with these lower teeth, which they didn't need to. I feel like if we just capped them, that would have been one way to get away with it. And that's the only point of contact as well.
So they were trying to do it basically to maintain some sort of posterior contact,
Yeah.
and not put so much force on the front teeth, right? But then they ended up basically creating a bigger problem due to the way that the jaw moves.
Absolutely.
Right? Is that what you're basically implying?
Yeah. So essentially, this is not really a functional prosthetic. It's almost like an aesthetic prosthetic.
Okay.
Right. So the patient is really just using it for smiling. Patient can't really function with it because you can't really bite on only just one tooth on each side.
Right.
And especially with implants, occlusion is the number one factor why most of the prostheses fail. Right. And here we don't
even
have
the implants fail.
Absolutely.
Yeah.
So which is, I think, one of the biggest factors of the screw loosening, of the fillings chipping off, and essentially of the prosthetic failing.
Right. And then some of that force being transmitted to the implants also.
Yeah.
Which, as we stated earlier, when we looked at the CBCT, actually what really caught my attention is that based off of the CBCT, when I was like evaluating this case, so this is her back right implant, and you could see like a bigger cantilever here. But then typically when we do these surgeries, what we try to do is we try to get, and this patient has pretty dense bone, right? So this implant measured to be about 10 millimeters long. There's about 18 millimeters of space to the floor of the nose. And so like, why didn't we basically place a large implant? What I love about this though, is that we basically, we didn't violate the buccal bone thickness, right? I think what we repeatedly say in videos, like when people try to do All-on-4, they try to get the longest, fattest implants.
Yeah.
But then they violate buccal bone thickness, and then over time, basically what ends up happening is the bone starts thinning out, and potentially peri-implantitis issues, let's say 5-10 years down the road. But the other issue is like they severely undersize this implant, right? And so, what we're always gauging things by is like bone implant contact, right? Basically, you're looking at the amount of surface area that you're going to gain, but like, with a 10 millimeter implant, I couldn't really read the width here. Like it's too whited out, but like, let's say 4 millimeter width.
Yeah.
We left a lot on the table in regards to like bone implant contact, what we could have had. And the problem is that it's actually on the same side too. And then the other issue is they basically squashed 6 implants all into this small area because this patient has monstrous sinuses, right? And so,
I think she would have almost been better off with just 4 longer implants instead of trying to squeeze 6.
Absolutely. Right. Yeah. And so this, I hate to say this, but sometimes this comes into cost too, right? Some people will charge you more money to get 6 implants. But what a lot of patients won't understand is that, exactly as you said, like there's no point of doing 6 implants if they're going to be shorter, and they're almost going to be impeding, because this patient in this limited area, now she's like hitting implants, and basically it's creating a congestion problem. And it almost may have been a contributing factor as to why they weren't able to place that implant longer if he placed this implant first, which is why we should always start with the posteriors first, right? But so Dr. Koo, with the surgery, when you're doing this in a few days, like what are your thoughts like in regards to like how you're planning on this case?
Yeah, so like I said, I would have, had I done the surgery first time, I probably would have used longer implants. So my tentative goal is to back all 6 implants out and then place longer and maybe slightly wider implants. So 4 in front of the sinuses, and maybe place what we call pterygoid implants, like far back, to give her the maximum support.
To avoid the cantilever. This before, options for this patient would be zygomatic implants going into her cheekbone. We also have the option of doing pterygoid implants. And these are all efforts that we can have to avoid cantilevers, right? And so those are called remote anchorage solutions. Other options would be like sinus lifting, right? But if her bone, like we'd have to like take into account, that's extra steps, right? So we'd have to do extra surgical procedures for her. So those are all on the table, right? In regards to like what's the best solution, zygo, pterygoid, sinus lifting, that's dentistry is very subjective. So we can always like tell patients, present their options, but any of them are good. But she's like younger 50s right now.
Yeah.
Something. Yeah. So if, we probably would try to tell them, hey, let's look at some of the other options before heading to like Zygos at this point, because Zygos can be fantastic, but we just want to avoid any potential complications.
Like this is one of the challenges we always see, when we're doing just single arch. I think it's very important to communicate to the patient the expectation essentially of just treating one arch.
Right.
Because a lot of patients, just because of finance, get one and done with one arch, but it leads to more problems later on when it could have been fixed if we just address those back two teeth at
Right.
least,
Right.
So sometimes you don't need to maybe do an all-on-4 on the lower arch. You can get away with it, but at least just getting some partial function, maybe with like a partial denture or at least those crowns in the back. Sometimes that lasts you a little longer because 2019 and 2025, it's barely been like 6 years
Right.
since she got it.
I think the big thing is that when keeping the patient's objective, right? So people are making a decision to take out, maybe she had some good teeth too, right? So that debate goes into like, hey, should we be looking at an all-on-4 if a person had, yeah, they got some root canal teeth, or they're missing some teeth, or they got some root canal failures, periodontal involvement, whatever it is, but they also may have some good teeth, right? So because dentistry is very subjective, if a person sought like what their opinions may be, I mean their options may be, then some options may be other like better versus others, and some may involve implants, some may not. So again, dentistry gets very subjective, but once we make the decision that we tell a patient that they have to take out their teeth, then it becomes imperative that it's got to last longer than 5 or 6 years, because you can understand the frustration where a patient spends like low 30s for one single arch, and 6 years later she's being told by the same dentist, hey, now you need to spend $70,000.
Yeah.
Right. So yeah, that's kind of didn't achieve the purpose. So that's very, but what you bring up also, like I want to talk about more in like other videos too. Definitely, well, we have two prosthos here, but having prosthodontist perspective, I think it's very easy for us as surgeons to basically say, oh yeah, of course we can do a single arch for you. But then obviously working with prosthodontists for all these years, prosthodontists are going to be the first people that get frustrated, because they're like, well, the overall objective is you want us to give a patient, you place these implants, you want us to put a prosthesis in this patient's mouth that's going to last a long time. But keep in mind, when we're looking at this person's opposing jaw and their teeth, there are certain things, there are certain factors that are now impeding me from doing a good job of making sure that this patient's teeth are going to last a lifetime, right?
Yeah.
Or as close to a lifetime
And
as
essentially,
possible.
you're like marrying one set to what she has, what the
Mhm.
patient has in the mouth on the lower
Right.
arch. And if at any time they decide to change that lower set, now all of a sudden that upper set is not
In
functional.
zirconia, yeah.
Essentially, they're gonna have to get both redone now.
Yep.
Right.
Right. So yeah, unfortunately, we have to have that uncomfortable conversation. Be like, hey, I know you came here looking for one, but if you do want the best long-term solution, then unfortunately, especially with this case, right, when we're evaluating the lower two. So now you're also going to be doing the lower also tomorrow, right, Doctor? I mean, well, a few days, Dr. Q, right? So all right, so let's look here. Like, did you see anything in particular? Like, you looked at the CBCT and everything.
Mhm.
I mean, obviously, she's had like a lot of atrophy of bone over the years,
Yeah.
but anything in particular? Are you guys doing like 4 or 6 implants down low?
6, I believe.
Okay.
Bone was a little bit thin where she's missing her teeth.
Right.
But there's plenty of bone around the existing molars.
Okay. So obviously, just trying to stay away from the mentals,
Mhm.
staying tilted in front of those, and then
Yeah.
trying to find some bone. Yeah. So one of the things that a lot of patients might have seen in videos before too, but if you have, one of the telltale signs of seeing if there's atrophy of the bone is like, you see, the vertical dip right there. But also, it's not just the height of bone that they're missing, but it's also the thickness of bone, and that's what we look at our 3D scan for. But is there anything else?
Yeah, I mean, I was just going to show that basically, pretty much she was biting on those back two teeth, and you could even see signs of, the supporting structures being inflamed here. That tells us that essentially she was really biting on only one tooth at this point. There's no widening here, and there's the only widening that she has on this tooth.
Right.
So one tooth, you can't really function a full arch prosthetic on that's kind of biting on one tooth.
Right.
Kind of led to its failure.
So this is just basically, unfortunately, one of those cases where, we try to get the patient what they're wanting and just go ahead with one arch. But unfortunately, because of what was going on in the other arch was pretty drastic in regards to the bite, the occlusion, it ultimately compromised her entire upper arch. Now, let me ask you another question. Had they used multi-unit abutments and properly done the case, and she's got kind of got bone loss all over the place. Like, what are your thoughts in regards to, like, would that have led to a different outcome in your
That's a good question. We were just talking about this earlier. I think if they had just placed 4 implants up top,
Yeah.
and minimized the cantilever,
Uh-huh.
and had slightly better occlusion in the front teeth,
Uh-huh.
I believe the case would still be in better position right now.
Yeah.
Just because you wouldn't have that much of an interference with the back teeth, you know.
Okay.
Because in the mouth, the highest force is in the back,
Mhm.
almost like a nutcracker.
Yeah.
So and you're putting the most compromised position with the back teeth. That I think is the reason why the prosthetic failed.
Yeah. Okay. All right. So good luck to do you have any thoughts?
I agree with Dr.
Yeah.
Said. I think that the distal implants, I think there's not enough space between implants, so there's a biological problem
Mhm.
and a mechanical problem due to the lack of passivity of the restoration. So we don't know if solving just with multi-units. I think the implant position, the distal implants are too close to each other. So I think there's biological problems, mechanical problems. So I don't think it's addressed altogether.
Yeah.
So for our viewers, could you kind of explain what the concept of passivity is?
So the restoration has
Yeah.
to sit at once, and when you screw it in, you have
Mhm.
to feel no resistance. Like
Right.
it fits like a glove or like a shoe. It has to be like what we call very passive. So there we can see in the X-ray on the right that those implants, like the restoration is not even sitting on the implants.
Like
Which
right over here.
that means that the screws are being bent. So yeah, right there. So that's not passive. So that for sure induces mechanical problems, screw loosening or screw fracture that can lead to biological problems. So we don't know what was first, the biological problem or the mechanical problem, but now there's both, like bone loss, screw loosening, prosthesis moving around. So yeah, both things have to be taken into consideration. The implant has to be placed in the right position, and then the prosthesis has to sit smooth.
Yeah. Yeah. Okay. All right. Good luck to you guys in a few days when you guys do this. But keep us updated. We're gonna get some footage
Yeah.
of the actual procedure and stuff. All right.
Sounds